So I'm going to speak about the spleen. The spleen's kind of interesting in the sense that the spleen is very commonly involved with a range of pathologies. But if you think about it, whether it's CT, MR, ultrasound, there's not a whole lot of different protocols. Linda spoke about doing protocols for the liver, and Charlie spoke about doing protocols for the coronaries, and I spoke about, different protocols looking at the stomach and for misdiagnosis. But it's somewhat challenging in the spleen. Now, there's some realities. One is that most splenic lesions are benign. Most of them are followed conservatively, or the truth is they're ignored. We rarely do splenic biopsies. And most studies of the spleen rarely look at multiple phases. They look at venous typically, though sometimes arterial is very helpful. And there really, even with the newest scanners, there's no new great developments. Now, it's interesting. There's a white paper from several years ago from the FACR looking at splenic lesions, and they spoke a lot about looking at a splenic lesion, a centimeter or greater, talking about doing all sorts of follow-up on those cases. This article by Seward made the point that, when you start looking at things, most splenic lesions are indeed benign. And if you don't have a history of malignancy, then probably it's not really worthwhile following them or doing a whole lot with them. 14% of patients at autopsy have various lesions. Hemangiomas, cysts, hamartomas, lymphangiomas, and granulomas are the most common thing. Again, in this article by Seward, the likelihood of malignancy is really low. Now, obviously, if you have a patient with left upper quadrant pain or fever or weight loss, anything that makes you think of some underlying malignancy or infection, then you look at the splenic lesions a little bit more carefully and think about them differently. But the incidental lesions, their conclusion in this article, and there have been several other articles recently, is that move on, don't bother following it. So what do? It's easy to say that, don't worry about it, it's probably nothing. But that probably nothing can theoretically be something, and how do you deal with referring clinicians? So things that I think about when I look at the spleen. One is I look at past medical history. So first of all, it's really good to have old films. There's a good chance if you see a small splenic lesion now, it was there 5 or 10 years ago, and that makes it leave alone, goodbye, good luck. But clinical history is important. Other CT findings are important. Current lab findings are important. Clinical history, again, becomes one of the driving forces. I'll also analyze the lesions, and we'll talk about that as we go through various lesions. Is it single or multiple? What's its size? Is there any enhancement? And so much also refers to beyond the spleen. Is it only in the spleen, or are there other organs involved in the process? Remember, at the end of the day, most of the time you're evaluating the spleen is because it's there. Every chest CT, we see some of the spleen. Every abdominal CT, we see all of the spleen. Obviously, there are times when the spleen becomes front and center. Staging lymphoma, an FUO workup, or left upper quadrant pain or palpable mass, all are things we need to think about.
This, of course, is a hot topic, and one which I think increasingly sites are getting involved with, different institutions and so forth. So I'm going to give you a little bit of an update, some of the established things and maybe a couple new things as well. I do not have any disclosures related to this that are relevant. So we'll start again with the classic. We'll talk about a little bit of an overview and definition. And we'll talk about some of the key trials. I think many of you, if not all of you, are familiar with the National Lung Screening Trial, but I'll mention a couple others that have been relevant and have played a role. A little bit about reimbursement and allied issues, and then the whole issue of setting up a program and the kinds of things that you encounter as you do, and some updates on that as well. So that's what we'll try to cover in the next little bit here. This slide just indicates how lung cancer remains a huge problem, and you can see it accounts, this is recent data, for 12% of all new cancer cases, putting it in the top echelon, and it is #1 for cancer deaths even today. So 22% of all cancer deaths, about just under a quarter, are lung cancer. And so it remains a huge challenge. And that, of course, is part of the impetus for screening. If we look at male versus female, the statistic holds here as well. Number one for both male and female, as I like to say for those of you who remember Virginia Slims, you've come a long way, baby, because it didn't used to be that case for women, but unfortunately it is these days. So I think there is no, I think both sides of the equation need to work on this, or need to have work done. And if we look at the trends, they are improving somewhat. You can see in men that improvement started longer ago than in women, and again, that is for the same reason that I mentioned a moment ago. But even in women, we're actually seeing a little bit of a decline, and the overall mortality has actually gone down. The survival has increased. And this just highlights a couple things, both of them, and that is, and this is a part of the argument for screening, looking back at the difference between when you catch it, meaning if you catch it locally, then you do far better than if you catch it regionally, meaning in the lymph nodes, and much, much better if you catch it than when you catch it when there's distance spread. So basically, the idea is you want to catch it when it's very local. And that is part of the underpinning of screening. The 5-year survival, as I say, has gone up. When I started overall, was probably in the 15 to 16% range. It has crept up, and now overall is around 20% if you do an average there.
Now, let me ask you, how many of you are routinely performing CTA in the body in your clinical practice and interpreting those studies? Okay. And how about MRA? So most of you are doing some of each, it sounds like. The objectives of this talk are to list some of the advantages and limitations of MRA and CTA, and to understand the diagnostic information available from each method, and discuss the role for each approach using some examples that I'll share with you in the various vascular disorders, especially in the body. I'm not going to be covering neurovascular diseases. And I'd say in the current state, the differences between the CTA and MRA are in their contraindications. There's certainly scanning differences, workflow differences, and diagnostic differences that include, artifacts, spatial resolution, and ability to image function, vessel flow, and organ function. And then we'll talk a little bit about new developments at the end, and specifically deep learning image reconstruction for CTA and MRA, some new developments there, as well as photon counting CTA and how that may impact clinical practice, what it is. And we'll weave in between here some forward-looking developments with 4D flow, MR. So what are the contraindications for CTA? Intravenous contrast, if somebody's had an anaphylactic reaction, perhaps renal insufficiency, although that now is a relative contraindication in many patients, as we understand that iodinated contrast agents, specific ones, can be safer in patients with renal insufficiency than once thought. And probably most importantly, radiation exposure, which limits the use of CT in pregnant patients as well as young adults and children. And we'll talk a little bit more about radiation exposure because, for the last 10 years or so after Brenner published some of his work, there was a lot of concern about CT radiation dose. It still is a significant contributor to overall radiation dose, and certainly the leading cause of medical radiation dose to the population. But our thinking around this has changed. And